हाइपरटेंशन इन प्रेगनेंसी डायग्नोसिस एंड मैनेजमेंट। हम हाइपरटेंशन कर रहे हैं, उसमें आता है सबसे पहले reducing the risk of hypertensive disorders in pregnancy. Symptoms of preeclampsia. Advise the pregnant woman to see a healthcare professional immediately if they experience symptoms of preeclampsia. Symptoms include severe headache, problems with vision such as blurring or flushing before the eyes, severe pain just below the ribs, vomiting, sudden swelling of the hands, face or feet. Antiplatelet agents. Advise pregnant women at high risk of preeclampsia to take 75 to 150 mg of aspirin daily from 12 weeks until the birth of the baby. Women at high risk are those of the following: hypertensive disease during a previous pregnancy, chronic kidney disease, autoimmune disease such as systemic lupus erythematosus or antiphospholipid syndrome, and type 1 or type 2 diabetes. Advise pregnant women with more than one moderate risk. ऊपर क्या था, सिर्फ एक रिस्क होना चाहिए, हाइपरटेंसिव डिजीज ड्यूरिंग अ प्रीवियस प्रेगनेंसी, क्रॉनिक किडनी डिजीज, ऑटोइम्यून डिजीज में एसएलई और एंटीफॉस्फोलिपिड सिंड्रोम, या फिर टाइप 1 टाइप 2 डायबिटीज में एक ही में अगर एक रिस्क फैक्टर होगा हम उसको एस्पिरिन स्टार्ट कर देंगे। बट पेशेंट जिनमें मोर देन वन रिस्क फैक्टर होगा, मॉडरेट रिस्क फैक्टर, वो 1 से ज्यादा होना चाहिए, उसमें हम 75 to 150 मिलीग्राम ऑफ एस्पिरिन देंगे डेली फ्रॉम 12 वीक्स अंटिल बर्थ ऑफ द बेबी। जो मॉडरेट रिस्क फैक्टर्स हैं, प्राइमरी ग्रेविडा जिसकी एज होगी 40 से ज्यादा या 40 से ज्यादा, ठीक है, 40 इयर्स और ओल्डर, ये 2 रिस्क फैक्टर होंगे। या फिर प्राइमरी ग्रेविडा होगी और प्रेगनेंसी जो एज ग्रेटर देन 40 इयर्स होगा, या फिर प्रेगनेंसी इंटरवल जो है प्रेगनेंसी इंटरवल मोर देन 10 इयर्स होगा, या इसका बीएमआई पेशेंट का मोर देन जो है बीएमआई 35 किलोग्राम पर मीटर स्क्वायर और मोर एट फर्स्ट विजिट, मतलब प्री जिसकी प्रेगनेंसी जो है बीएमआई जो है फर्स्ट विजिट पे उसका 35 किलोग्राम पर मीटर स्क्वायर होगी, और फिर फैमिली हिस्ट्री ऑफ प्री-इक्लेम्पसिया। अदर फॉर्म क्रिटिकल एजेंट जैसे प्रोजेस्टेरोन, नाइट्रिक ऑक्साइड डोनर्स और लव ग्रेविटी हेपरिन हम नहीं देंगे न्यूट्रिशन सप्लीमेंट्स में, हमने पेशेंट को रिकमेंड नहीं करना। मैग्नीशियम, फॉलिक एसिड, एंटीऑक्सीडेंट्स, विटामिन सी, ई, फिश ऑयल्स, एल्गल ऑयल्स सोली फॉर प्रिवेंटिंग हाइपरटेंसिव डिजीज ड्यूरिंग प्रेगनेंसी। उसमें फॉलिक एसिड देते हैं, जिंजर देते हैं, नोज़ामेटिन के लिए फॉलिक एसिड इज वेरी इंपॉर्टेंट, बट प्रिवेंशन ऑफ हाइपरटेंसिव डिसऑर्डर प्रेगनेंसी के लिए हमने नहीं जो है एडवाइस करना। डाइट में सॉल्ट रिस्ट्रिक्शन जो है वो प्री-इक्लेम्पसिया और जेस्टेशनल हाइपरटेंशन के लिए नहीं है, बट डाइट रिस्ट्रिक्शन क्रॉनिक हाइपरटेंसिव अगर पेशेंट आ सकती है उसमें वी कैन रिकमेंड। लाइफस्टाइल बिल्कुल सेम होगा जैसे कि नॉन हाइपरटेंसिव पेशेंट के लिए। एडवाइस ऑन रेस्ट, एक्सरसाइज एंड वर्क टू वुमेन विद क्रॉनिक हाइपरटेंशन एट रिस्क ऑफ हाइपरटेंसिव डिसऑर्डर्स ड्यूरिंग प्रेगनेंसी एज हेल्दी प्रेग्नेंट वुमेन। अब पेशेंट डायबिटीज होगी तो उसके अपने अलग से जो डायबिटीज है वो उसमें पढ़ेंगे। असेसमेंट ऑफ प्रोटीनूरिया हाइपरटेंसिव डिसऑर्डर्स ऑफ प्रेगनेंसी, इंटरप्रेट करना है प्रोटीनूरिया मेजरमेंट को फॉर प्रेग्नेंट वुमेन, कंटेस्ट ऑफ फुल क्लिनिकल रिव्यू ऑफ सिम्टम्स, साइंस एंड अदर इन्वेस्टिगेशन फॉर प्री-इक्लेम्पसिया। हमने क्या करना है, ऑटोमेटेड रीजन स्ट्रिप रीडिंग डिवाइस फॉर डिप्स्टिक स्क्रीनिंग फॉर प्रोटीनूरिया प्रेग्नेंट वुमेन इन सेकेंडरी केयर सेटिंग्स। अगर डिप्स्टिक स्क्रीनिंग जो है पॉजिटिव है 1+ और मोर यूज, हमने इसके बाद डिप्स्टिक जैसे आती है प्रोटीनूरिया के लिए तो हमने एल्बुमिन क्रिएटिनिन रेशियो या फिर प्रोटीन क्रिएटिनिन रेशियो यूज करना है टू क्वांटिफाई प्रोटीनूरिया इन प्रेग्नेंट वुमेन, ठीक है। अब इसमें इंपॉर्टेंट पॉइंट है कि डू नॉट यूज फर्स्ट मॉर्निंग वाइट टू क्वांटिफाई प्रोटीनूरिया इन प्रेग्नेंट वुमेन and do not routinely use our 24-hour urine collection to quantify proteinuria in pregnant women. If using protein creatinine ratio to quantify proteinuria in pregnant women, use 30 mg per millimole as a threshold for significant proteinuria. ठीक है, 30 mg per millimole. And if the result is 30 mg per millimole or above and is still uncertainty about the diagnosis of preeclampsia, consider करना है हमने retesting on a new sample alongside a clinical review. तो हमारे पास आता है if using albumin creatinine ratio as alternative to protein creatinine ratio to diagnose preeclampsia, pregnant and hypertension, तो हमने यूज 8 मिलीग्राम पर मिलीमोल एज अ डायग्नोस्टिक थ्रेशोल्ड। ये किस चीज के लिए है? अगर हम यूज कर रहे हैं एल्ब्यूमिन क्रिएटिनिन रेशियो, ठीक है, एज अल्टरनेटिव टू प्रोटीन क्रिएटिनिन रेशियो, उसमें हमने 8 मिलीग्राम पर मिलीमोल अगर आ जाए एल्ब्यूमिन क्रिएटिनिन रेशियो, तो इसका डायग्नोस्टिक बन जाता है, ठीक है, 8 मिलीग्राम या उससे ज्यादा। इफ द रिजल्ट इज 8 मिलीग्राम पर मिलीमोल और अबव and there is still uncertainty about the diagnosis of preeclampsia, consider करना है हमें retesting on a new sample. Then management of chronic hypertension in pregnancy. Pre-pregnancy advice. Offer करना women को chronic hypertension, refer to a specialist in hypertensive disorders of pregnancy to discuss the risk and benefits of treatment. Advice करना women को who taking angiotensin converting enzyme inhibitors or angiotensin receptor or angiotensin 2 receptor blockers, that there is increased risk of congenital abnormalities if these drugs are taken during pregnancy. ACE, ARBs पेशेंट ले रही है तो आप उसको बताना है कि ये जो है प्रेगनेंसी में सेफ नहीं है, एंड टू डिस्कस द अल्टरनेटिव एंटी-हाइपरटेंसिव ट्रीटमेंट द हेल्थ केयर प्रोफेशनल रिस्पांसिबल फॉर मैनेजिंग ऑफ हाइपरटेंशन इफ दे आर प्लानिंग अ प्रेगनेंसी प्री कंसेप्शन। ये आपने एडवाइस करना है कि हेल्थ केयर प्रोफेशनल के पास जाए, बिकॉज दीज ड्रग्स आर टेराटोजेनिक, सो प्रेगनेंसी सेफ ड्रग जो वो यूज करे फॉर ट्रीटिंग हाइपरटेंशन। टू डिस्कस alternative treatment with the healthcare professional responsible for managing the condition. If ACE inhibitors or ARBs are being taken for the conditions such as newborn disease, stop anti-hypertensive treatment from taking ACE inhibitors or ARBs if they become pregnant. And offer करने alternatives को. Advise women who take thiazide or thiazide-like diuretics, they have increased risk of congenital abnormalities and neonatal complications if these drugs are taken during pregnancy. And to discuss the alternative anti-hypertensive treatment with the healthcare professional responsible for their hypertension. सही. Advise women who take anti-hypertensive treatment other than ACE inhibitors, ARBs, thiazide diuretics that the limited evidence available is not showing increased risk of congenital malformations such with treatments. जो लेबेटोलॉल है, नाइफेडोपीन है, मेथालडोपा है, हम वो रिकमेंड करते हैं प्रेगनेंसी में बिकॉज दे आर सेफ एंड देयर इज नो एनी इंक्रीज रिस्क ऑफ कंजेनिटल मालफॉर्मेशंस विद सच ट्रीटमेंट। ट्रीटमेंट ऑफ क्रॉनिक हाइपरटेंशन में ऑफर करना है प्रेग्नेंट वुमेन को क्रॉनिक हाइपरटेंशन ऑन एडवाइस ऑन वेट मैनेजमेंट, एक्सरसाइज, हेल्दी ईटिंग एंड लॉवरिंग द अमाउंट ऑफ सॉल्ट इन देयर डाइट। क्रॉनिक हाइपरटेंशन के लिए ये है बट नॉट इन प्रीक्लैम्सिया एंड gestational hypertension. It has nothing to do with the salt. So that's why restricting salt is unnecessary. हाँ, बैलेंस डाइट का हम जरूर कह सकते हैं. कंटिन्यू विद एक्जिस्टिंग हाइपरटेंसिव ट्रीटमेंट इफ सेफ इन प्रेगनेंसी और स्विच टू अल्टरनेटिव ट्रीटमेंट अनलेस सस्टेन्ड सिस्टोलिक ब्लड प्रेशर लेस देन 110 of Hg, sustained diastolic blood pressure less than 170 of Hg, or the woman has symptomatic hypertension. बिल्कुल there is no word to explain कि हाइपरटेंसिव ट्रीटमेंट स्टार्ट करें जब तक कि उसका बीपी जो है सिस्टोलिक 110 से अबव हो, डायस्टोलिक 70. लेकिन अगर उससे एक लोअर चला जाता है देन वी हैव टू स्टॉप द एंटी हाइपरटेंसिव ट्रीटमेंट. ऑफर करना एंटी हाइपरटेंसिव ट्रीटमेंट टू प्रेग्नेंट वुमेन हु हैव क्रॉनिक हाइपरटेंशन हु आर नॉट ऑलरेडी ऑन ट्रीटमेंट इफ दे हैव sustained systolic blood pressure of 140 mmHg or higher and sustained diastolic blood pressure 90 mmHg or higher. ठीक है, इन पेशेंट्स को हमें देना है 140 सिस्टोलिक और 90 डायस्टोलिक. इस पे हमने इसको हाइपरटेंसिव ट्रीटमेंट स्टार्ट करनी है. When using medicines to treat hypertension pregnancy, the aim of for a target जो blood pressure है वो 135 by 85 mm of Hg है. कंसिडर करना है लेबेटोलॉल टू ट्रीट chronic hypertension in pregnant women. कंसिडर करना है हमने नाइफेडिपिन का फॉर्मैन विद लेबेटोल इज नॉट सूटेबल, मेथालडोपा इफ बोथ लेबेटोल और मेथालडोपा नॉट सूटेबल. एंड लेबेटोलॉल के अपने कुछ कंट्राइंडिकेशन जैसे एस्थमेटिक पेशेंट्स में और कार्डियक फेलियर पेशेंट्स में हमने नहीं देना नाइफेडिपिन का अपना. सो these are treat saying कि कंसिडर करना है लेबेटोलॉल को ट्रीट करने का अपने प्रेग्नेंट वुमेन एंड कंसिडर नाइफेडिपिन फॉर वुमेन इन whom लेबेटोलॉल इज नॉट सूटेबल, मेथालडोपा इफ बोथ लेबेटोलॉल and नाइफेडिपिन नॉट सूटेबल. Base the choice on pre-existing treatment and side effect profile, risk, fetal effects, and women preference. Offer penetrative operation experience effect 50 mg daily from 12 weeks. Offer placental growth factor based testing to help rule out preeclampsia between 20 weeks up to 35 weeks of pregnancy if woman with chronic hypertension is suspected to developing preeclampsia. तो हमें क्या टेस्ट करना होता है? प्लेजेंटल ग्रोथ फैक्टर, और ये कब करते हैं? 20 से अप टू 35 से प्रेगनेंसी हम कर सकते हैं. If woman chronic hypertension is suspected to develop preeclampsia के लिए. Antenatal appointments. In women chronic hypertension, schedule and traditional antenatal appointments. Based on individual needs of the woman and a baby, this may include weekly appointments अगर hypertension control नहीं है, and appointments every 2 to 4 weeks. Hypertension is well controlled. Weekly जिसमें control poorly controlled and it's controlled 2 to 4 weeks. Timing of birth. Do not offer planned early birth before 37 weeks pregnancy chronic hypertension whose blood pressure is lower than 160 to 110 mm of Hg with or without antihypertensive treatment unless there are other medical indications. For women with chronic hypertension whose blood pressure is lower than 160 to 110 mm of Hg after 37 weeks with or without antihypertensive treatment, timing of birth and maternal and fetal indications for birth should vary between the woman and senior obstetrician. If early birth is planned, offer a course of antenatal corticosteroids and magnesium sulfate if indicated with a NICE guideline stick. Postnatal investigations, monitoring treatment in women with chronic hypertension who have gave birth, measure blood pressure. ये postnatally कह रहे हैं. For the first 2 days after birth, at least once between day 3 and 5 after birth as clinically indicated. If antihypertensive treatment is changed after birth. In women with chronic hypertension who gave birth, aim to keep the blood pressure lower than 140/90. Postnatally कह रहे हैं आके हमें ब्लड प्रेशर को लोअर रखना है, 140 और 90 से लोअर रखना है. एंड chronic hypertension एंड कंटिन्यू करना है एंटीहाइपरटेंसिव ट्रीटमेंट इफ रिक्वायर्ड. चॉइस ये एंटीहाइपरटेंसिव ट्रीटमेंट विद postnatal period. Offer a review for hypertensive treatment 2 weeks after birth, ठीक है, with their GP or specialist. If woman has taken methanol to treat chronic hypertension pregnancy, stop within 2 days after birth, change to an alternative antihypertensive treatment. And offer करना है woman with chronic hypertension a medical review 6 to 8 weeks after birth, ठीक है. And management of gestational hypertension, assessment and treatment of the gestational hypertension. In women with gestational hypertension, a full assessment should be carried out in a secondary care setting by healthcare professionals trained in the management of pregnancy disorders of pregnancy. Women with gestational hypertension take account of the following risk factors that require additional assessments and follow-up: nulliparity, age 40 years or older, pregnancy level more than 10 years, family history of preeclampsia, multi-fetal pregnancy, BMI of 35 kg or more, gestational age at presentation, previous history of preeclampsia, gestational hypertension, and pre-existing vascular disease and pre-existing kidney disease. Offer women with gestational hypertension the test and treatment listed in table. Now, degree of hypertension blood pressure 140/90 to 159/109, and this patient will not routinely admit, and we will offer treatment if the BP remains above 140/90, and we will aim to keep blood pressure of 135/85 mmHg or less, and blood pressure measurement once or twice a week depending on blood pressure until BP is 135/85, and dipstick proteinuria testing is 1 or twice a week with BP measurement, and blood tests are measured for blood count, liver function, renal function test representation, and then weekly. And placental growth factor based testing, carry out placental growth factor based testing on one occasion according to NICE guidance. Fetal assessment, we will offer fetal auscultation at every antenatal appointment, carry out ultrasound assessment of the fetus at diagnosis, and if normal, repeat every 2 to 4 weeks if clinically indicated. And we will carry out CTG if clinically indicated. And in severe hypertension, blood pressure of 160 mmHg and diastolic 110 mm of mercury or more, we will admit that patient. If BP falls below 160/110, then manage as for hypertension. But BP of 160 to 110 will admit that patient as the patient is more at risk of developing preeclampsia and eclampsia. HELP syndrome, FLP. So we will admit that patient, we will offer pharmacological treatment to all the women. We will aim for BP of 135 by 85 mm of Hg, and we will measure blood pressure every 15 to 30 minutes until BP is less than 160 to 110. And we will do daily dipstick proteinuria. We will do daily blood test. We will measure full blood count, liver function test, renal function test at presentation, and then weekly or more frequently if deteriorated. Prenatal growth factor, we will carry out prenatal growth factor based testing on one occasion, and why it's done, because it's done between 20 weeks to 35 weeks in those patients who are increased risk of developing preeclampsia. Fetal assessment, we will offer fetal heart auscultation at every antenatal appointment. We will carry out ultrasound assessment of the fetus at diagnosis, and if normal, we will repeat every 2 weeks if severe hypertension persists. We will carry out ultrasound assessment of the fetus at diagnosis, and if normal, we will repeat every 2 weeks if severe hypertension persists. And we will carry out CTG diagnosis and only if clinically indicated. Use an automated reagent strip reading device for dipstick proteinuria in secondary care settings. PIGF based testing जैसे पहले पढ़ा था, and testing to rule out preeclampsia in women presenting with to rule out preeclampsia in women presenting with suspected preeclampsia. For example, gestational hypertension between 20 weeks up to 35 weeks of pregnancy. We will consider labetalol to treat gestational hypertension. We will consider nifedipine, same thing जैसे ऊपर पढ़ा था. It's same timing of birth. It's in gestational hypertension. Record maternal and fetal thresholds for planned early birth before 37 weeks in women with preeclampsia. Threshold for considering early birth could include but are not limited to any of the following features for preeclampsia: inability to control maternal blood pressure despite 3 or more classes of antihypertensive in appropriate doses, maternal pulse oximetry less than 90%, progressive deterioration renal function, liver function, renal function, hemolysis, platelet count, ongoing neurological features such as severe intractable headache, repeated visual scotoma or eclampsia, placental abruption, reverse and diastolic flow in the umbilical artery, Doppler stomatry. इनमें हमें क्या करना है कि हमने अर्ली बर्थ करना है, ठीक है. These are the thresholds for considering early birth. And we will involve senior obstetricians in any decisions on timing of birth, and we will discuss with the anesthetic team. We will involve pediatrician. We will offer IV magnesium sulfate in a course of antenatal corticosteroids if indicated. Timing of birth in women with preeclampsia. Weeks of pregnancy, timing of birth before 34 weeks, continuous surveillance unless there are other indications for planned early birth. We will offer IV sulfate in a course of antenatal corticosteroids from 34 to 36 plus 6 weeks. Continuous surveillance unless there are indications. जैसे ऊपर पढ़ा था, when considering the options for early birth, take into account women's and babies' condition, risk factors, medical comorbidities, orders of pregnancy, and available of neonatal unit pads. 37 weeks on initiate birth within 24 to 48 hours. because 37 weeks पे initiate करना चाहिए birth को if severe hypertension is not controlled. patient जो 37 weeks पे आ गई है. blood pressure postnatal में वही at least 4 times a day while woman is inpatient, and at least between day 3 and 5 after birth on alternative days until normal blood pressure was abnormal day 3 and 5. In women with preeclampsia or did not take antihypertensive treatment and have gave birth, start antihypertensive treatment if the pressure is 150 by 100 mm of Hg or higher. Ask women with preeclampsia who gave birth about severe headache and epigastric pain each time blood pressure is measured. Women with preeclampsia who take anti-hypertensive treatment at birth may have a patient 4 times a day, every 1 to 2 days for up to 2 weeks, and transfer to committee advice that if women is offered treatment and no hypertension. इसमें है hematological biochemical monitoring में मैया platelet count और serum creatinine 47 hours after birth. Offer करना women को preeclampsia and still have proteinuria 1 plus or more at 6 to 8 weeks after birth. A further review by GP or specialist at 3 months after birth is to assess kidney function. Consider referring women abnormal kidney function assessment 3 months for specialist kidney specialist. Vital monitoring chronic hypertension in women with chronic hypertension, carry out ultrasound for vital growth and notified assessment of black Doppler 28, 32 and 36 weeks. In women with chronic hypertension, offer करना ultrasound को for vital growth and notified volume of black Doppler at 28 weeks, 32 weeks and 36 weeks. You will do Doppler at 28 weeks and 32 and 36 weeks. Now, in women with preeclampsia or severe gestational hypertension, we will repeat cardiography if woman reports change in fetal movements, jam bleeding or rampant deterioration in maternal condition. And women who need additional fetal monitoring, carry out ultrasound for fetal growth, amniotic fluid assessment, and umbilical Doppler at 20, 32, 36 weeks, at least 2 weeks before previous gestational age of onset if earlier than 28 weeks and repeating 4 weeks later in women with previous preeclampsia that resulted in birth before 34 weeks. इन पेशेंट्स में हमें फ्रीक्वेंट करना है और जिस जेस्टेशनल एज पे उनको सिम्टम्स हुए थे या उनको जो है जिस जेस्टेशनल एज पे कॉम्प्लिकेशंस अराइज हुए थे उससे 2 weeks अर्लियर विल मॉनिटर द पेशेंट. ठीक है. प्रीवियस जेस्टेशनल एज में उसको प्रीक्लेम्शिया हुआ था दैट्स रिजल्टेड इन बर्थ बिफोर 34 weeks या प्रीक्लेम्शिया with a baby whose birth weight was less than 10 centile. IUGR में भी हुआ था due to chronic hypertension या preeclampsia, intrauterine death और placental abruption. इनमें हम क्या करेंगे? Ultrasound, fetal growth, amniotic fluid volume assessment and umbilical Doppler velocimetry starting between 28 and 30 weeks or at least 2 weeks before previous gestational age of onset if earlier than 28 weeks and repeating 4 weeks later in previous pregnancy. 2 weeks earlier हम तब करेंगे earlier than 28 weeks. इंट्रापार्टम केयर में एडवाइस करना है ट्रीट करेक्ट वुमेन को अपरेंसिव डिसऑर्डर्स ऑफ प्रेगनेंसी अनलेस द रिकमेंडेशंस आर इन स्टॉप. ये ऊपर पड़ा था ब्लड प्रेशर में ऑर्ली वुमेन हाइपरटेंशन 15 to 30 मिनट्स ब्लड प्रेशर लेस देन 60 to 110 वेजिस फॉर हाइपरटेंशन. केयर ड्यूरिंग एपिड्यूरल एनाल्जेसिया. एपिड्यूरल एनाल्जेसिया में हमने प्रीलोड नहीं करना. ये सब स्पाइनल में करते हैं, एपिड्यूरल में हमने प्रीलोड नहीं करना. सेकंड स्टेज ऑफ लेबर में जो है हमने रूटीनली जो है लिमिट नहीं करना ड्यूरेशन ऑफ सेकंड स्टेज ऑफ लेबर बट कंसीडर करेंगे ऑपरेटिव और असिस्टेड बर्थ सेकंड स्टेज ऑफ लेबर फॉर वुमेन विद स्वेयर हाइपरटेंशन. हमने जिस पेशेंट को स्वेयर हाइपरटेंशन है उसके सेकंड स्टेज ऑफ लेबर को हमने शॉर्टन करना है. मेडिकल मैनेजमेंट ऑफ स्वेयर हाइपरटेंशन प्रीक्लेम्शिया और eclampsia critical care settings anticonvulsants if woman is critical care setting of severe hypertension severe preeclampsia has a previously had eclamptic fit give IV magnesium sulfate. IV पे magnesium sulfate हम देंगे. preeclampsia हुआ है और कंसीडर करेंगे गिविंग IV magnesium sulfate to women with severe preeclampsia and consider the need for magnesium sulfate treatment if one or more of the following ongoing recurring severe headaches visual scotoma, nausea or vomiting, epigastric pain, oliguria and severe hypertension and progressive deterioration in blood tests such as rising creatinine, liver transaminases or falling platelet count. Use a collaborative eclampsia trial regime for administration of max sulfate. Loading dose of 4 gram should be given IV over 5 to 15 minutes followed by infusion of 1 gram per hour maintained for 24 hours. If the woman has had an eclamptic fit, the infusion should be continued for 24 hours after the last fit. Recurrent fit should be treated a further dose of 2 to 4 gram given IV over 5 to 15 minutes. लोडिंग डोज हमने दिया पेशेंट को एंड बर्थ शुड बी विद इन 24 hours of the last fit and the recurrent fit should be treated after a further dose of 2 to 4 gram given IV over 5 to 15 minutes. Do not use diazepam, phenytoin or other anticonvulsants as an alternative to max sulfate in women with preeclampsia. Antihypertensives to treat women with severe hypertension who are in critical care during pregnancy or after birth immediately with one of the following: labetalol oral or IV, oral nifedipine or IV hydrolazine. In women with severe hypertension who are in critical care, monitor the response to treatment to ensure that their blood pressure falls, to identify adverse effects for both the woman and the baby, and to modify treatment according to response. Consider using up to 500 ml of crystallite fluid before or at the same time as the first dose of IV hydrolazine in the antenatal period. Corticosteroids for fetal lung maturation if early birth is considered likely within 7 days in women with preeclampsia. Offer a course of antenatal corticosteroids in line with the NICE clinical guidelines on the preterm labor and birth. Corticosteroid to manage HELLP syndrome. Do not use dexamethasone or betamethasone for the treatment of HELLP syndrome. Fluid balance and volume expansion. Do not use volume expansion in women with severe preeclampsia unless hydrolazine is the antenatal hypertensive. ये कह रहा है कि do not use volume expansion in women with severe preeclampsia because there is a risk of pulmonary edema. So hydrolazine, if until unless hydrolazine is the antenatal antihypertensive, we will not use any fluid expansion. In women with severe preeclampsia, limit maintenance fluids to 80 ml per hour unless there are other ongoing fluid losses, for example hemorrhage. C-section versus induction of labor, that totally depends on the severity of the hypertension. If either it's mild hypertension or severe preeclampsia, according to the clinical circumstances and women's preferences. Referring to the critical care, level 3 care will be given to the severe preeclampsia who need ventilation. Level 2 care will be given to step down from level 3 or severe preeclampsia any of the following complications: eclampsia, HELLP syndrome, hemorrhage, hyperkalemia, severe oliguria, coagulation support, IV antihypertensive treatment, initial stabilization of severe hypertension, evidence of cardiac failure, abnormal neurology. And level 1 care is preeclampsia with hypertension and ongoing conservative management of severe preterm hypertension and step down treatment after birth. Antihypertensive during the postnatal period, including during breastfeeding. Advise women with hypertension who wish to breastfeed that antihypertensive medicines can pass into breast milk, and most antihypertensive medicines taken while breastfeeding only lead to very low levels in breast milk, so the amount taken in babies are very small, would be unlikely to have any clinical effect. Most medicines are not tested in pregnant or breastfeeding women, so disclaimers in manufacturer information are not because of any specific safety concerns or evidence of birth. Make decisions on treatment together with the woman based on our preferences. As antihypertensives have the potential to transmit to breast milk, consider monitoring the blood pressure of the baby, especially those born preterm who have symptoms of low blood pressure for the first few weeks. When discharged home, advise women to monitor their babies for drowsiness, lethargy, pallor, cold peripheries before feeding. Offer enalapril to treat hypertension women during the postnatal period with appropriate monitoring of the maternal renal function and maternal serum potassium. For women of Black, African or Caribbean family origin and hypertension during the postnatal period, consider antihypertensive treatment with nifedipine or amlodipine if the woman has previously used this to successfully control her blood pressure. For women with hypertension in the postnatal period, if blood pressure is not controlled with single medicine, consider combination of nifedipine, amlodipine, and enalapril. If the combination is not tolerated or is ineffective, consider either adding atenolol or labetalol to the combination treatment or swapping one of the medicines already being used for atenolol or labetalol. When treating women with antihypertensive medication during the postnatal period, use medicine that are taken once daily when possible. Where possible, avoid using diuretics or ARBs to treat hypertension in women in the postnatal period who are breastfeeding or expressing milk. Treat women with hypertension in the postnatal period who are not breastfeeding or not planning to breastfeed in line with the NICE guidelines. Advice and follow up. Risk of recurrence of hypertensive disorders of pregnancy. Now this is the recurrences are given. Any hypertension in pregnancy, approximately 21%, 25 women, there's a risk of recurrence. Preeclampsia, 1 in 5, and gestational hypertension, 1 in 5, that's important. Now, chronic hypertension, these are terms used in these guidelines. These are definitions. Chronic hypertension is a hypertension that is present at the booking visit or before 20 weeks the woman is already taking antihypertensive medication. When referred to maternity services, it can be a primary or secondary etiology. What's eclampsia? A convulsive condition associated with preeclampsia. Gestational hypertension is a new hypertension presenting after 20 weeks of pregnancy without significant proteinuria. ALP syndrome is a hemolysis of elevated liver enzymes, low platelet count. Hypertension is a blood pressure of 140 mmHg, systolic or higher, systolic 90 mmHg or higher. Multi-fetal pregnancy okay with more than one baby, it is twins, triplets. Preeclampsia, new onset of hypertension over 140 mm of Hg systolic or over 90 mm of mercury diastolic after 20 weeks of pregnancy, and the coexistence of one or more of the following new onset conditions: proteinuria, urine protein creatinine ratio of 30 mg per millimole. That's very important to remember. Or albumin creatinine ratio of 8 mg per millimole, at least 1 gram per liter 2 plus on dipstick testing. Or other maternal organ dysfunction, renal insufficiency, creatinine 19 micromole per liter or more, 1.02 mg per 100 ml or more, liver involvement, elevated ALT or AST, or 40 international per liter with without right upper quadrant or epigastric abdominal pain. Neurological complications such as preeclampsia, neurological complications such as eclampsia, altered mental status, blindness, stroke, clonus, severe headache, or persistent vision scotoma. Hematological complications such as thrombocytopenia, platelet count below 1,50,000 microliter, or DIC or hemolysis. And neurotransmitter dysfunction such as fetal growth restriction, abnormal tonality Doppler, waveform analysis, or stillbirth. Severe hypertension is blood pressure over 160 mmHg systolic or over 110 mm of mercury diastolic. Severe preeclampsia is preeclampsia with severe hypertension that does not respond to treatment associated with ongoing or recurrent headaches, visual scotoma, nausea, vomiting, epigastric pain, oliguria, severe hypertension, as well as progressive deterioration in laboratory blood tests such as rising creatinine or liver transaminases, or falling platelet count, or failure of fetal growth, or abnormal Doppler findings. These are some important definitions actually. And anything like new I didn't find. Okay, so that's all about the hypertension